The need for home healthcare was always there, but it was basically on a need basis. That means if I have something which is not being addressed or I cannot go to hospital, I find a way of getting it addressed.
Welcome to the Blue Circle. Thank you all for joining in today. It's such a big privilege and a pleasure to reconnect with everyone, our distinguished panelists who are handpicked because of the think input and the rich experience they bring in. And thank you to our distinguished audience for joining us. We've received over 200 registrations, and most of whom are CEOs, CXOs, and business heads. Many of them are repeat visitors to our webinars, which is very encouraging and motivates us to provide even higher levels of dialogue through our online modes as well. For those of you who are new with us today, the Blue Circle is a network and ecosystem curated for business leaders to help them manage disruptive times and become future ready. We focus on four fundamental sectors, which are healthcare, e-mobility, energy, and real estate. We also present socioeconomic insights, which ultimately determine the evolving complexion of the market. In response to the COVID challenge, the Blue Circle has also accentuated its digital presence. One of the many modes we employ is our weekly webinar series and our digital publication. And in addition to this, and you would be happy to know that we're very soon launching an exclusive digital platform for leaders, a LinkedIn-like platform for leaders, wherein we will present them with the opportunity of connecting with people just like them, high quality curated content and meaningful conversations and business opportunities across these four sectors. So those leaders who are interested, please do write to us. We've also begun our outreach to our first 1,000 to 2,000 members, which we plan to bring on board before we launch the app in December. And the topic for today's session is rising demand for home care. Home health care is witnessing significant growth the world over. India is also experiencing a surge. The fear that inpatients in hospitals could catch COVID has added to the thrust which it was already receiving from traditional drivers as well. We are privileged to have invited prominent practitioners and thought leaders from the sector to discuss tailwinds, headwinds, and the way forward for home healthcare in India. In the best interest of time, I will just quickly mention their respective names and designations. We have with us Dr. Gaurav Thukral, EVP and COO, Healthcare at Home, Dr. Mahesh Joshi, CEO, Apollo Homecare, Mr. Rajiv Mathur, Founder and Executive Chairman, Critical Care Unified, Mr. Vipin Pathak, Co-Founder and CEO, Care24, and the Chair and Moderator for the session is Mr. Pavan Choudary, best-selling author, CEO, French multinational Vigon India, Chairman, Medical Technology Association of India, and sits on several boards across the country. Welcome, sirs, and thank you very much for joining. Kindly note that we will have Q&A towards the end of the session. Some of you have already shared excellent questions there with the moderator already. And now I request Mr. Choudary to please chair and moderate the session, sir.
Great. Thank you very much, Siddharth. And welcome to the audience and welcome to the panelists. The word hospital comes from the root hospice, HOSPES, which means a host or a guest. So hospitals started as inns for pilgrims, and there used to be a large number of pilgrims in those times. And then eventually they evolved into the structures or institutions as we see them today. And healthcare moved slowly from the home with the advent of surgery to the hospital. However, now we see, especially post-COVID, healthcare coming back to home. With this brief backdrop, let me go to Dr. Mahesh Joshi and ask him as to what he thinks are the drivers of home healthcare today. Mahesh.
So I think the most, if I have to look at, I would probably say it in two parts pre-COVID and post-COVID. In fact, COVID by itself has become a very important driver. So I will keep it for the second part. If you look at pre-COVID, so the need for home healthcare was always there, but it was basically on a need basis. That means if I have something which is not being addressed or I cannot go to hospital, I find a way of getting it addressed. So that's how it was. So if you look at drivers, one is the desperate need on the side of the family on having somebody to take care of a person in the family who has undergone a procedure or who is unwell. So the large need today is for post-discharge care. The second one is around the chronic diseases in terms of people who have to recurrently visit hospitals for a procedure, for a follow-up, for an investigation, etc. That is also another important need that is there. This is another important driver. Third, the social reason is that the conventional family support structure has gone away from the ecosystem because the families are becoming smaller and smaller. And therefore, either the parents are not staying with you and they are there in some other town, or if they are staying, you don't have time to support them when they need and you cannot take leave of, etc. So these are some of the most important drivers. And post-COVID, this change in consumption of healthcare behavior is the most important driver, where pre-COVID, most of the people believed that good healthcare can only be consumed within the four walls of the hospital, has changed significantly, at least for the non-urgent, non-emergent, non-procedure based services. And quite a few people have started seeking healthcare akin to other services like retail business in India. So I will pause here.
Very, very good point. So let us exhaust this family piece. What you have said is that there is a desperation among families because families themselves, as they have evolved, they differ today in their willingness to divide the labors of care. Some families can take it up, but most families going towards the nuclear setup may have difficulty in taking it up. And of course, there's work-life balance, so some desperation may be coming because of that. And also there is some level of satisfaction and social esteem still connected in India in caring for the sick at home. So you want to care for them at home, but still cannot do it yourself. So home healthcare services become that much more urgent. Great points, Mahesh, to begin. And let me come to Rajiv, and then I'll go to Vipin and then Gaurav for discussing this tailwind piece behind home healthcare further. And on this, in the second round, when I discuss the headwinds, I'll start with Gaurav to have equity, and Gaurav not to come in the last of the at the end of the queue in the second round. So let me go to Rajiv. Rajiv.
Yeah, hi. So I'll just sort of take off from where Dr. Joshi left, and I'll sort of share a bit of a story, because my view is that the fillip that home healthcare is getting now, I mean, like he mentioned, the drivers were already there and people were utilizing it, but the kind of fillip and catalyzation that is happening now is something through experience. And a wider audience today in the country has experienced care at home. So the story I want to share is like, in my previous incarnation, I was in the IT sector. And in 1998, 99, I was in the thick of this thing called the Y2K problem globally. And until then, when we used to talk to clients and customers in the US or Europe or wherever, the model was that, hey, why don't you send your people, let them come and work in our facilities here, and that would be great because we can manage them. But what happened was, when Y2K problem came in, they said, hey, here's a problem we've got. Can you take it away and can you do it for us? And that's when a lot of work was being done in India, in the software factories here. And they found that, it was equally good, just the processes they were implementing in their offices, et cetera, all that was happening. So there was a tremendous buy-in that happened to offshore software processing. Similarly here, with COVID, for instance, a a wider section of the population has experienced home care, with governments declaring that for mild cases you could take home isolation and all of that, and they went for that option because they couldn't get hospital beds or couldn't get admissions, etc., etc. All of that, was scared to go into hospitals, so they had the experience, and I think that experience is going to pay off in the next few years in terms of adoption of home care for a variety of ailments. So that's a Kickstarter, which I think has come in willy-nilly, although through a problem, but then it's going to support the whole home care bit quite a bit for the industry. So that's what just one point there, that I think this is a inflection point for home health care.
No, point very well made. And we have found that we are all coming from the healthcare sector. The pace of reform in the healthcare sector is glacial. They say it is a renovator's delight. Our sector is a renovator's delight. It moves very slowly. It is conservative. But whenever a problem comes, there is a lot of change which happens. And you are right that the pivot of or the fulcrum of this change has become COVID, where people experienced, for example, people experience telemedicine also. We have 50 million people going on the telemedicine portals in 3 months, and twice, 8 minutes each. So they experienced many new things in this time, and they are going to continue positively forward towards after their positive experience with some of these. Great points. Coming to Vipin. Vipin, what would you like to add to the tailwind? Vipin, we can't hear you.
Sorry, I think it got under. Hey, so I think two more points, if I may add. So one is, what Mahesh was mentioning earlier, that the income levels and the overall disposable income levels, if you see, especially in the metros, increasing, and primarily also because of like the families are becoming more dinged families, like people having less time and things like that. That has sort of been a driver for, I would say, midterm. So I would say it has been there for some time, maybe 10, 15 years, like when we have started valuing time over money. And that change in itself is sort of saying that, if I were to take care of my family versus, working elsewhere and, coming back. So overall disposable income would be one category that I would say that is a driver. Second, I would say that, technology in itself has advanced so much in the last 15 years, 20 years, that is enabling a lot of things. So today, if we were to actually, things like ventilator, like no one on earth, I mean, like, 15 years or 20 years back, you said that, I'll put a ventilator at your home. People will not accept. People did not believe that these engineering tech, which was supposed to be in a hospital kind of a setup, can they be actually deployed at a home, and whether I will be able to trust that technology. So that, one is the engineering technology. Secondly is like, the believing and acceptance of that technology. So across medical equipments, do-it-yourself devices, data monitoring, remote monitoring. So a lot of things has kind of, I would say, helped in the overall awareness for the consumer that things can be done at home. The data is always in sync. So whenever there's a proactive intervention required, somebody could come. So all that interoperability of overall patient from the journey as well as data perspective has sort of helped. Third, I would say that from a COVID perspective, one thing that has been my realization is that we are actually sort of kind of going back to earlier concepts. Like earlier, if you see, health is a state matter. Health is not only a individual matter. Health is not only a family matter. Health is not a community matter, but it's actually a state matter. So a lot of community has kind of taken up that responsibility. Like people have in their own apartment buildings, they said that I would want to set up a facility. Now, if you see, against a hospital, because the hospital beds are full, and that is going to be the case. If you look at India, there is a 7 million shortage of beds on earth. It's not possible to kind of invest in that kind of capex. So there was one saying that we used to kind of have earlier, that the best hospital bed is the one at your home. And that concept has now gone to a level that community overall has started doing things on their own, has started. So you would have seen a lot of communities setting up their nursing home kind of a facility, putting some oxygen cylinders, putting equipments, making sure that there is a emergency doctors that can come and stuff like that. So I would say that that has sort of propelled the idea that things can be done at home, things can be done in a smaller setup, things can be done at home. So I would say these three factors: community, technology, and income levels. These three would be some of the drivers from my perspective.
Excellent points. So, what Mahesh has said, the family piece, what was driving home health care generically because of the changes in the family or requirements of the family. What Rajiv brought in was how COVID as an event really turned things, because people were forced to experience new things and they found them good. What you have brought in is the technology and the community piece post-COVID, which has also changed and pushed this forward. What about the perspective of the patient? The patient, the payer, the provider, and the government. What from these perspectives are the tailwinds for home healthcare generically, Gaurav?
So thank you, Pavan, and I think my all the senior panelists have mentioned all the tailwinds, but I would like to put a very different perspective to the whole thing. Definitely, COVID has been the precursor, but at the time when COVID happened and everybody said stay safe, stay home, it became very, very imperative to take healthcare delivery at home, which we were already doing, but it became very important, and that's where the whole perception changed, where the government was forced to bring the telemedicine guidelines, and a doctor or a patient who would say jab tak doctor haath nahi lagayega tab tak hum kaise pata chalenge. The whole scenario changed from a physical mindset of home healthcare, where I need a person, which is a linear growth, one patient, one nurse or attendant, to saying that it became a remote monitored phygital model, where the scale was so huge that one nurse was able to manage hundreds of patients, and hence home healthcare providers were able to manage lakhs of COVID mildly positive or asymptomatic patients, which decreased the burden on the critical care facilities or on the acute care facilities. The second thing I think which happened was that the very first time, rather than saying कि मैंने एक nurse दे दिया or I provided a service at home, and what is the outcome, which you are always looking in the hospital, the government or the payer, whether it was insurance or the government, they started looking at outcomes in terms of recovery rates, in terms of deaths in home isolation, right? So this was something in our own piece we were doing in small bits and pieces, but now this became very, very evident. So I think the whole thing of changing, saying that we always say that the lack of manpower is, I would say, a bottleneck to scale. So here also we could say that through technology, through remote monitoring, through, I would say, the phygital aspect of home healthcare, lakhs of patients are being managed. We are looking at good outcomes out of that. And I think that's where it is going to change, because this can be adopted into management of many more chronic diseases, where again the burden on the acute care can be done. Secondly, I think the point which has already been made is that all the home healthcare providers, which are in an organized market, less than 5% of the total market, are stationed in maybe tier 1 or tier 2 cities. But this again remote monitoring model could be practiced across India from anywhere in India. So again, the access, affordability, and the scale. I think these were the inflection points which are going to propel and be big tailwinds for home healthcare.
Agreed. Telemedicine surely became a very big tailwind. And telemedicine guidelines released by the Niti Aayog and the Ministry of Health and Family Welfare in time also allowed the practitioner to practice distance education in addition to what he was allowed to practice through the MCI protocol. And this was really one very big thing. And we also did a research. We found that one of the important reasons why people took to telemedicine, aside from the advantage which it gives to the patient and the doctor, and reduces the doctor's cognitive load and reduces waiting room pressure, and the government, the capacity increases and the payer is also happy, the patient was happy. because often in interacting with doctors, we are or not doctors, healthcare workers like all of us, he, in a feudal society, he may lose dignity, or he may not be treated in the most cordial manner by a healthcare worker. We have found that this is also one reason why he is very keen to go on telemedicine, just as the low income person is going to e-commerce, buying through e-commerce, the maids and all, there is a huge inflection point here, buying through e-commerce to preserve dignity while shopping. Otherwise, they have to dress up well, they have to stock well, and still the shopkeepers may misbehave or fellow shoppers may misbehave. Similarly, the medical shopper also got this advantage. And there are several others on telemedicine, which we've discussed in a separate program. And the other point which you said, capacity, the government also benefits now. If telemedicine and home healthcare is going to expand, then the 20% global disease burden which we have, against which we have only 6% of the beds and 8% of healthcare workers, including doctors, that is not such a big limitation, because if you needed one doctor per 1,000 people, now you can handle 1,800 people as per a McKinsey study through that one doctor. The payer also will benefit, and the biggest benefit will go to the patient, the home healthcare patient. He gets the convenience, the freedom and the independence, the normalcy of his schedule can be preserved. He can set his own pace for physiology. Friends and family can visit him whenever he's okay with that. There's a lower chance of infection, especially with COVID. This has become very important. Cost and saving reduction, time and effort saved, and also that satisfaction of being among one's near and dear ones. So I feel that many people benefit in many ways, and which together becomes a huge headwind. I come to Gaurav now to discuss the tailwinds, the obstacles to home healthcare going forward. Gaurav.
So, Pavanji, I think the biggest obstacle to home healthcare is that there is not a single person who has said that it is not a requirement. Every person I've met over the years said, oh, it's a very big requirement. But when we are working in home healthcare, there is one organized and unorganized sector. Then there is one generic and a specialty delivery sector. And then there are people which I say are delivering quality care and are trying to do a credible job rather than some of those. So what I feel when we talk to people that payer is the biggest problem, if in India it is 99% out of pocket, when I talk to the payer, they said, how do we get the credibility which we get into the closed doors of the hospital? Now, credibility comes through regulation, which we are still away. But short of regulation, I think now we have internationally accredited standards, which becomes self-regulation. And I don't think that we stop there also. Once the self-regulation is there and we can show credible outcomes, the credibility builds for the patient, for the provider, for the doctor, and for the payer. I think if this credibility part can be resolved through clinical protocols, through outcome-based therapies, specialized therapies, I think this big headwind can definitely be settled, and it all can become a very integrative medicine, which during COVID times, the government, the IRDA definitely understood that they could not manage only with hospitals. So integrative approach between the district healthcare facilities, home healthcare providers, remote monitoring, hospitals and ICUs. So I think that whole model can come into shape.
Excellent point. So you are saying that or what you are alluding, there's a patchwork of regulations which are not uniformly applied or monitored. There has to be a good, credible, standard work which is already being done by QAI. Then you are speaking about education, training, and licensure, the certification piece also, so that the service standards are set and the service becomes more credible. Perhaps you are also referring to not only credibility of the regulatory piece, but also the credibility of experience. Where at home, the patient has some environmental hazards like sanitation, physical layout, etc., which has to be factored in. Then there is the difficulty of balancing patient autonomy and risk by the caregiver. This has to be balanced in. And continuous monitoring, which gets interrupted sometimes at home, also has to be factored in through technology and better protocol. And the whole, as you said, the entire piece from the hospital, and another occasion you said the flow of healthcare should be smooth from the hospital handoff to home as if nothing has changed. Great points, Gaurav. I would like to come to Mahesh. Mahesh, what would you like to add to this?
So, Pavan, if we
The
look at
headwinds.
the historic model of healthcare delivery, there are two nodal points. One is the clinician, and second is the hospital. Whatever they say, whatever they think is what people perceive is the standard or gold standard of healthcare delivery. I think hospitals have to change their mindset and feel that home healthcare is complementary to their care and it is not taking away their business. This is first. The second thing is clinicians have to incorporate continuum of care at home as a part of the care plan. According to me, these are the two most important headwinds for healthcare to become an accepted norm of standardized care delivery or quality care delivery as a part of the care management of the patient. Because what we are doing is we are addressing the desperate need of the patient family and the patient right now. We are not integrated as part of the care protocol or care plan. I think this will come once when people change their mindset out of the customer experience feedback that they have got of the services done by professional players. And the second important thing would be when insurance takes it up and then drills it across to the hospital system or to the doctors in saying that, look, we feel that we have got credible players, they have accreditation, there are standards, and we will be only compensating this much for this procedure for these many stays in the hospital and these many stays at home. I think this will change that.
Great point. So mindset of the customer also has to change. You're absolutely right, because sometimes the customer has heard stories of incompetent healthcare worker at his home, somebody else's story. He may have had some elder abuse also or he might have heard stories of elder abuse by family. He might also be embarrassed sometimes at his living conditions to accept home health care. So, seeing from the headwinds piece, these are some of the hurdles which we have to overcome mostly perceptually by making sure that these myths are busted. Coming to go ahead, Mahesh.
So, in many ways, COVID has already done that shakeup. So I think that's the blessing in disguise because that shakeup has happened. Hospitals have started thinking about home healthcare, so they rapidly launched home monitoring programs, etc. Right? Clinicians also started thinking, now how do I connect with my clients? Let me see if I can, continue the care at home. So this shakeup has happened. Now the credible players have to build upon this, provide customer experience, and as Gaurav said, we have to provide some outcomes onto this, show the cost benefit to the insurance guys, and I think then the industry is good to go. They would have crossed a very important barrier.
Very good. You brought in the payer piece also. Very good. Yeah, Gaurav, come in.
Just wanted to add to what Mahesh sir said. Across Medicaid in USA, one of the things which they monitor for paying a home healthcare provider or a stratification of a home healthcare provider is the readmission rates, right? So even if we start with that under the care of a home healthcare provider, the quality care which was given, what was the readmission rates, that is a very simple outcome which the payer can monitor to pay the providers. So these are a few examples just to add to what Mahesh wanted to say.
No, excellent addition. And this allows us to go a little deeper into this mindset and payer piece. Mahesh brought in the mindset piece, which also means academic mindset. In our curriculum for medical colleges, we do not have home-based care integrated into the curriculum. House call curriculum at Hopkins, etc., should be studied and seen if we can bring in similar stuff which has benefited home healthcare there. Second point you brought in was the payment piece. So the payment philosophy is per patient based. But if we have this patient based chassis of payment philosophy, then the home healthcare physician is at a disadvantage because he will not be able to attend that many patients as he can attend. Of course, now with telemedicine, things are changing. So these are things also which need to be factored in. Very, very good intervention, Gaurav, to Mahesh's fine point. Coming back to Rajiv. Rajiv, what would you like to add to the headwinds piece?
Okay, so if we look at it from a very ground level and actual implementation of healthcare in the home, there are a couple of things that probably need to be done over a period of time. The family or whoever is the next of kin in the home plays an important role. So I think there has to be some amount of education and some amount of even training that can be provided to enhance the value of the care that is being given at home. It's a joint and a concerted effort of the care provider plus the family, because one of the main reasons why care is being provided at home is in the comfort of the environment with people around, etc., all of that. But then there are certain essential protocols that need to be followed in terms of hygiene, etc., all of that, right? So if there is some awareness and some bit of education that is provided to the family responsible, then I think it will enhance the value, or some people call outcome, on the treatment or the treatment plan. That's one. The other is as we make it more pervasive, rather than sticking to the metro cities and all the rest of it. But if we have to make it more pervasive, then there are two factors again. Regardless of technology, and I completely believe and I agree with everybody that technology can make a big difference in terms of scaling up, in being able to enhance the reach and all the rest of it. But we still need better quality resources, the base level resources that come in for care, for example, nursing care, or enhanced training or enhanced modules, which can lead to some sort of certification where they actually are considered as certified caregivers for the home. And it has a larger canvas that you paint on, including bedside treatment, etc., all of that. And there's one resource which is sitting there, which we could utilize again to alleviate the problem of shortage of resources, is again use the family, because a lot of them actually get involved in the treatment plan. And for some simple procedures and all of that, again, if there is some amount of training that is provided to them, that only will enhance the type of care that is being given to the patient ultimately. So I think in areas of education, training, certification, there is some work we need to do together with the government and other agencies to significantly enhance the value of care that is being provided in the home.
Excellent intervention, Rajiv. You are saying that the family also needs to be educated. And you are saying, of course, in minor jobs also it could be educated, but more importantly, the point which you're making is it has to be educated about the importance of care and the importance of the caregiver. Often we find that the caregivers are appalled by how the family treats the patient. So both sides need to develop new focal lengths in their lenses. And I was remembering there is a TV show which I used to conduct, where a psychologist came. I forgot her name, and she was speaking about this film where the elders are abused. Rajesh Khanna film, where the elders are abused by the family, and she proved to me by asking two different cohorts the same question. The question was whether the children were wrong or the parents were wrong. Who was at fault? She asked the question of unmarried students. Everybody said that the parents were the victims, the children were wrong. But when she asked this of people who were married, couples, all of them said that the children perhaps were right and parents could have looked at things differently. So it was a difference in focal lengths. So sometimes our caregivers also do not see those things from the family's point of view, and often the family doesn't see it from the caregiver's point of view. And if this is sorted out and certification, etc., which you are talking about, is brought in, it can also become that much more insurance friendly. What would you like to add to the headwinds piece, Vipin? Vipin, the headwinds piece, we can't hear you.
Sorry, I was on mute. So I think I would want to kind of quickly touch upon some points that I feel might have been left out. So one is the supply piece. So today, if you look at the, so I'll touch upon supply, I'll touch upon say provider piece, and I'll touch upon say the system and ecosystem. From a supply perspective, you look at the real providers, which are the nurses, caretakers, therapists, doctors. From a home visit perspective, their earning levels are not very high. They're not earning a lot of money with working with the providers. So they always compare it with say Uber drivers. They always compare it with say delivery boys. They always there's a comparison, and I don't think we pay really that great. So I think it's very competitive. So and that's why you see that there's a lot of churn that is happening overall at a overall if you look at that level. The reason being also if you look from the supply standpoint in a hospital, all these are cost centers. For us, they are the real profit centers, and a profit center earning that less money is not very exciting. So, now comes the part of that, the providers, like, why are we not paying much? I think we are not innovating enough. We are not innovating in terms of model that would make sure that the earning level goes up and the cost goes down for the consumer. So are there possibilities? There are multiple possibilities, right? So the onus is on the providers. Now, why are the, but as soon as I say that, I know that that we are at fault, I have to give an excuse that why are we not able to do it. So I think from a provider perspective, we are trying to do too many things. As a home healthcare provider, if I look at it, so we literally have to take the supply from base zero. So we have to take people, a lot of cases, they're not being trained ever. They're not being, have any kind of experience. So from a supply standpoint, we have to take from base zero, do a training, do certification, every single thing on the supply to make them job ready. By the time we have made them job ready, somebody else is trying to kind of pay them better, they'll leave there. Now, from the other perspective, now we have to do marketing. We have, all the sales marketing, a lot of effort is being sent in that, because we most of us would have external or internal investors, so we have to kind of show the growth scale and stuff like that. So I think there's a growth that we require. We have to invest in marketing. What else can we do? So we have to invest in marketing. Now then there comes a part of operations. So we have to from an operations perspective, if you look at it, starting from say booking to revenue realization, there is a huge journey. It's not like while it is, I'm saying easy, but there are cases where there will be an NPA. People are used to a certain type of job. Something bad happens, there will be an NPA. Now these are all thin margin businesses. Remember that we are not operating at margin business which are 80% plus gross margin business. It puts a huge thrust on us. So I think that provider trying to do too many things we have to do, because if we have to survive, I think that pushes us to do the normal job, not put a lot of time and energy into innovation. Now the third piece, like in terms of solution, the ecosystem. The trouble with the ecosystem is that we are all working in silos. So the clinician, hospital, nursing homes, insurance, pharma, everyone is working in a silo. Now, if you look at say home healthcare across globe, so we all understand it's a downstream, right? So people will go to say OPD, then maybe acute care, last they come to home care. Globally, the acquisition is a solved problem. So they would get to say a customer request from say insurance, or in US parlance, if you say the insurance are actually bought the hospital. So there is it's integrated system that you'll get a request. Your job is to do the service well. You don't even have to take the revenue. There is another company which is doing it. Change Healthcare is going to take care of all the revenue realization, collections, everything is sorted. You just have to make sure that that job is done. Job done means your billing is done. Now, from our perspective, we all have to, I mean, if you look at a patient's journey, we all, I'm sorry to kind of go into detail, but if I'm adding on this, understand that for the same patient, insurance is spending money on Google, Facebook, blah, 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 all sort of advertisement, they get that patient. Hospital again has to spend a lot of money to make branding, put all the fancy, stuff, large hospital, 1,000-bed, blah, blah, all that shit, right? Then they get, fancy doctors. Again, they go to pharma, then, 20% discount, 30% discount, blah, blah, blah. All of us are spending a lot of money into acquisition, whereas we are unable to provide an integrated solution to the patient. Like if you're able to do that, if you're not working in silo, it's a single thread of the patient, right? Starting from say, OPD to, end of life. If you are able to integrate at a system level and technology, I mean, like, the bidding me, like it's not about say partnership and you banging head with, front of hospitals and, clinicians saying that, give me patients and, they take patient. No, like nothing. It has to be a technology integrated solution so that we are able to kind of actually innovate into home healthcare, bring new solutions. So that's three parts to what I wanted to say.
No, great points. Basically, you have said that employee training, retention, utilization is a big piece. And overall, this is a problem which the industry has to handle. It is an employee-intensive, highly intricate job to provide home health care, which requires end-to-end integration. Just having a part of the puzzle doesn't work so well. So, and unless we have that, we will not have the kind of margins which will continue to make this sector attractive for the investor.
Right.
Great point. What would you like to add to this, Gaurav?
I'll continue with what Vipin said, and I tend to agree with him, where the same patient is being acquired by so many people differently, rather than one person doing the acquisition role and other people doing the service role. But yes, the models are available in India also through pharma, as Vipin mentioned them for hospitals and other providers in the West. But one thing I feel that in the innovation, the other thing which has to happen is that akin to the hospitals, hospitals also earn through high margin procedures, right? The major bulk of profits which come is through doing a CABG or a TCAR but not by a medical admission or by treating a dengue. So home healthcare also has to move into specialty care. And if you are moving to specialty care, you can command better pricing because you're doing a complicated, complex job and hence a better margin. And after that, if you are controlling your cost of acquisitions and your delivery cost and everything, your indirect cost, I think you can make decent profits. But if you are into a generic care, where the only thing which I would have put it, that you are just providing attendance service or your margins, gross margins itself are 10 to 15%, then the bottom lines don't look that attractive. So I think here we have to follow the hospital model of saying that we do a TCAR also and we do a dengue also. So that service portfolios have to differentiate. And secondly, again, till the time it is a linear model where we say that one person cost cannot be reduced to one person. Hospital can still do it. They can have one nurse treating maybe 6 patients, 8 patients. Here at home, you cannot. And again, if you can have one nurse or one physio through technology managing various patients against the margin, again, the margins are there. So I think, again, we have to be very, very innovative in the Indian context, given the mindset change and things are happening, to get more margins and hence most profits.
So you're interestingly bringing in an earlier dialogue which Mahesh and Rajiv had on this. Rajiv comes from the specialty piece. He provides intensive care units at home. And Mahesh connects it end to end, from wound care right up to intensive care units, and the hospital piece is also there. So what you have done is you kind of summarized the gist of that discussion without being present there. You are saying it's like a train. It has to stop at all the stations so that it can board even the 1 or 2 people at the smaller stations who may be wanting to board. But it has to concentrate its stops or have longer stops on some station where the main customer is going to come from, or the profitable customer is coming from, or they are coming in droves, like you said, TKR or things like that. Rajiv, would you like to add to this? Because your experience as an intensive care unit provider is very important to this group.
Yeah. So I do agree that your service portfolio or the canvas that you paint on needs to be larger as you move along. But from a value, I think the first and foremost thing that we need to look at is what is the value that is being provided to the patient or to the patient's ecosystem in terms of delivery of that service. And at times, if there is, if you create a very vanilla volume-based model, then clearly that changes the whole sort of financial modeling and the profitability in that. Yeah. But then that has to be addressed in the same way. So, for example, if you look at the home healthcare industry, if there was a focus of only providing a medical attendant, but then that goes up to a certain scale that it does meet the profitability or the business viability requirements, it's fine. But I think somebody did mention earlier that that some of the home healthcare companies are trying to do everything together in one basket. Yeah. So that is where the challenge comes in, where the problem that you may have with the ICU type of setup may be quite similar to the problem that a medical attendant shapes up or provides at a patient's home, in terms of the gravity of the issue, in terms of the value that the patient is getting, in terms of the problems that the patient is facing. Yeah. So yes, it's what needs to spread because there is an opportunity in a number of areas. But I think it has to be recognized that some of these segments need to be dealt with as businesses in their own right. So they cannot be sort of amalgamated and look at the whole thing, as one sort of entity and one business. And again, we've seen this a number of times where different types of businesses, when they've sort of merged in one whole cauldron, none of them get the attention that they deserve. So excellent. I think even from a financial modeling and a business perspective, if we are able to define that and manage them appropriately, then I think it's a very effective model.
What a forthcoming debate between friends. So basically what you're saying is that you are disagreeing a little with what Gaurav has said. You have said focus may be important tomorrow. Right now, if we are not getting profits, we are also not getting profits, and the broad spectrum people are also not getting profits. So the narrow spectrum people may start thinking that we are not getting profits because we are not broad spectrum enough. But this, you are saying, may not be the real diagnosis of the situation. The real diagnosis and the remedy may lie elsewhere. What Gaurav is saying, too much focus is a frozen state of mind. He is saying that you may have some patients of dengue also who will not give you high EBITDAs, high ARPOBs, but still keep those patients of dengue also, allow them board into the train because they may provide other opportunities or develop other indications which you may serve more profitably. What is Mahesh's view? Mahesh.
I will take on your example of train. So if you look at the viability or sustainability of a train, if it is a general class, it will always be challenging. If it is pure AC class, then you're talking of only fewer segments and fewer routes on which it will run. So if you really want to have, especially at this time, once you understand that on this route there are high paying people, etc., then you may convert that entire train into a first class train. But at the current time, the way I look at it is that the industry itself is not very mature. So you have to, it is from a point of view of viability, having broad base helps. Secondly, look at from a patient's need. the same critical care patient might have to be downgraded after 3 weeks. Now, will you hand it over to somebody else? Or a basic level patient turns little bad, will you now hand it over to somebody else? Now this patient needs investigation, will you say we don't do? So I think it's very important for us to understand that at the current time when the industry is not mature, what will help you is every opportunity, every footfall that comes to you, there is a potential to do some or the other service for them, improve your LTV coming from the client. And as you go further, you find your niche areas and create those things, because ultimately, worldwide, there is enough data to say, and even insurance will not reimburse the unskilled home health care. Most of the reimbursement model for home health care are coming from skilled home health care. So my point of view is that you be broad-based, create your focus 2 or 3 service lines, which you can be differentiator in terms of how you customize the product, or how your delivery is, or how your customer experience is, and then create margins out of it. And that margin will only come if you make it less resource dependent.
Yeah. So, and to add to what, yeah, go ahead, Gaurav.
Yeah, completely agree with Dr. Mahesh, sir. I think what we now need to look at home healthcare is out of hospital care. And rather than treating the patient, we have to look at treating the disease, or we have to say that this is now going to be a disease management portfolio where every aspect of the patient outside the hospital needs to be addressed. And if you are making a margin at every transaction, whatever is small, it is a viable business model. So some things will give you a better margin, some will give you less margin, but at the end of the day, you will not be losing money on that. So that's my take to whatever Dr. Joshi said.
Yeah, and to add to what you and Mahesh have said, is Vipin's point. Vipin is saying if you are operating in silos and you are only able to deliver a silo-based service, then integrate technologically with the other pieces of the puzzle. Now, we should all give Rajiv another chance to say whether that kind of integration is possible with your competitors or not. Rajiv.
Yeah, absolutely, absolutely. So, just as a slight distinction, what I might like to add here is that the focus is not on the product or the set of products or services that are being rolled out individually, but the focus is on the patient. And I agree that whatever the needs of the patient are, arguably it may be for medicine delivery or it may be for some lab tests, etc., etc. As long as we are able to integrate that for the patient, then that is definitely a viable model and definitely what is required by the patient as well, so that they don't go to different agencies, etc., for different needs. Yeah. And in terms of general care, there may be again some minor specializations in terms of the ailments, but broadly, if we look at essentially what home healthcare is providing is top end of nursing care, whether it's at the ICU end or it's at a more chronic long-term end, but it's high end of nursing care, which is the centerpiece of the service that is being delivered. Everything else is like supporting that endeavor there. So yes, it is eminently possible to integrate, and the focus should be the patient and the needs of the patient. And whatever it takes in terms of the other healthcare services should be provided in there. And if those have to be handled individually, then they need to be looked at individually as businesses separate and a separate, like a separate division or separate entity or whatever. That's my view.
Yeah, like some hospitals look at onco beds and cardiothoracic beds as separate profit centers. Great points. Coming to Vipin. Vipin, what are the 2 points which are very important for the way forward from your point of view? Then I'll go to everybody with the same asking for the same 2 points, and then I go to the questions. Vipin.
Yeah. Broadly, my way forward, one is I would say that industry has to kind of work together on this. So by industry, what I mean is starting with the insurance. So unless until the insurance is keenly interested and game on this, I think that the journey starts there. So we need to of integrated with the insurance. And the good news is that they already have started covering a lot more than what they were doing pre-COVID. And that journey is, I'm sure that is kind of going to go a long way on that. And I was seeing one of the questions that was on the Q&A on this chat room, and somebody has asked that, what happens beyond metros, the home care, and beyond metros. And I think it would be my sense that a lot of, and since I come from technology background, I keep on talking about, that technology can change the world and all. I think a lot of new models have to come. So home care, as we are kind of growing, the home care will become a very, very separate industry where it will have verticals. So as I think Gaurav, Mahesh, everyone is saying that there will be, specialization. There will be some people who will be doing more horizontal on that, and there will be people who will be doing more specialized on that. And to give you an example, I think the best home care was done previous to, maybe 100 years back, when the community was taking care of the family. When the community, so in any village, if you go, no one lets elder die because there was no one who could attend him. There was a community care which was existing. So we have to kind of come back and figure out a model. And there are interesting pilots which have been done. So I'm talking to somebody in Japan. I want to kind of take an example of that. Is that when you are helping an elderly in doing any activity, you get points. And that point you can redeem. So now what happens is that the same concept which was helping the people in community, you can actually make a model out of it. Whether it is going to be a financially viable model, what is the business model around, what are the technologies involved. I think there is a long way to go. But there are in pocket success cases that is coming, and we all have to figure out. Individually, that what are the new models in home care that will come, which is going to change the scene. And for that, obviously, we need investments, which is a little chicken and egg thing, because it will need the good investors coming in. I think the investor interest is again going to be playing an important role in this. So that's my sense overall.
Great. So insurance and new business models, maybe new financing models also, which are not measuring perhaps the service which is provided, but the prevention which happens. Great points. Coming to Mahesh, what would you like to say are your two main points forward as the way forward?
To me, the future of home health care today, home health care is post-episodic, right? It has to transform completely, and it should become pre-episodic. The entire thing of home health care should be around reducing visits to the hospital, reducing the cost of care, reducing the time spent at the hospital, and anticipating adverse events that can happen at home, etc. So I think this is the most important journey which home healthcare will have to take. Today it is post-episodic, and this is far limited. One, in terms of opportunity, second, in terms of the impact. But if you look at this entire piece around pre-episodic, it's a huge, much wider canvas, and much more effective, both in terms of the cost of care, also on the impact that it delivers. So that's the most important change which the industry needs to have. And the second thing is, I think the sooner the hospitals realize that they need to have either their own home healthcare delivery model or work in partnership with the home healthcare provider, because that is their sure shot way of engaging with the customer, and they spend a far much higher cost on the digital marketing and lot of on the ground marketing, which yields very little tangible results. It is a far better investment to have this continuum of the brand, continuum of the care, and continuum of the trust beyond their hospital things. These are the two most important things.
Excellent points. On pre-episodic, Russia had many decades ago had tried the pre-episodic way to reward physicians. So that if your clients will not become patients, then you will be rewarded. So there was a tendency on the part of the patients to take healthy people as their clients and deny clienthood to the unhealthy ones or who could fall ill. Have you thought this eventuality can come, or you feel in home healthcare insurance this kind of eventuality is unlikely? Mahesh.
I think we are already seeing that the insurance is rewarding good behavior versus bad behavior, right? The premium cost changes. So I think it will lead to a huge cultural change. Right from childhood, people will become conscious of this. Parents will become more responsible. I think these are triggers. In the immediate things, you start seeing this as adverse outcome, but in the long term, this might play out as the long term positive consequence of this.
And also, I agree with you that there will be a chance of fraud in any kind of scheme, any misuse. We'll have to work through filters which detect those frauds and limit those frauds in how the policy is formulated. Great point.
So Pawan, I think this is an important piece, and a lot of learnings from the remote monitoring in COVID has to go into it. If you look at the number of people who would have got admitted by default, if we had bed available during that time, the amount of money people would have spent, and ultimately the amount of added investigations and the treatment things that would have been done for most of the patients is just, I mean, I wish we can create this co-study between all the home health care providers. It's a significant cost burden reduction, stress reduction, and also more effective availability of the healthcare system for those who need it. So I think if we work in this direction, and as I mentioned earlier also that, while we are talking right now is a small community focused on the private payer healthcare group, the large success of home healthcare is when the public healthcare system adopts it. And that's where is the bang for the buck as far as the impact on the healthcare system is concerned.
Excellent point. So such cost benefit analysis studies are a way forward to convince not only the insurance provider, the payer, but also the government payer. A great point. What would you like to add to that, Rajiv? 2 points on way forward.
Okay.
Rajiv, we can. Yeah.
Can you hear me now?
Yes.
Can you hear? Okay.
Yeah.
Yeah. So there are two attributes to this industry. Number one, it is evolving and it will continue to evolve for a while. And therefore, there's going to be learning over the next few years. And there are enough innovative people who will then bring in the appropriate models to deal with a situation of that type. The other is that that there is a huge need which is emerging. And if we have to provide pervasive and affordable home health care, or like Dr. Gaurav Thukral said, out of hospital care, it has to be pervasive and it has to be affordable. And for which there is an important pillar of having the right resources. Arguably, there is efficiency that can be built in, and I'm a complete supporter of technology, etc., all of that. But there is a critical mass which is required to be available to deal with those needs that are emerging in that area. So whether it is in metros, whether it is in tier 1, whether it is in tier 2, but if we do want to make it pervasive and make it affordable at the levels of quality that we need to deliver in the home, then clearly we push for insurance, which will help in the affordability factor. But at the same time, when the market grows there, you need to have the appropriate resources. And by resources, I mean in terms of the medical staff and adequate investments and all of that available to be able to address that need and opportunity. Or it might be a tsunami that is building, hits us, and we don't know what to do at that point in time, where there'll be a depreciation in the level of service that we give, which we absolutely cannot allow in the industry. So those are my points there.
Great points. Great points. Coming to Gaurav in the end with his 2 points on the way forward. Then I have 2 questions, one for Gaurav and one for Mahesh. Gaurav.
So I think the other panelists have said enough, and it's always difficult to speak after Dr. Joshi because he echoes my thoughts as if it's me speaking. So completely agree to whatever the panelists said. I think to add to what Sir said is that it is again the quality delivery, regulation and self-regulation, which is going to take care of all the aspects which we have said, right? And that is the only thing which is going to give confidence to the payer also. As Dr. Joshi said, today government has understood they could not have treated so many patients in the hospital. They could not have tested. They could not have spent that much amount of money. The amount of money which is being spent on a patient on home isolation is far less than what is being done in a hospital without ICU also. So I feel the way forward is or to get ambit of organized home care better with the pillars of accreditation and technology. And once this is done, the whole thing of patient acquisition and pair will definitely get resolved.
Okay. So my question to you, Gaurav, is coming from Anjan Bose, who is the chief advisor for Tata Medical and Diagnostic as well as Praxis Global Alliance. He asks, are pure home care focused companies finding it difficult to compete with home care segment in hospital groups from patient acquisition to costing points of view? Basically, he's asking what Mahesh has done from Apollo, is it making your life difficult? Go ahead, Gaurav.
So I still believe, sir, that these two models have advantages and disadvantages, right? The choice of the provider rests still with the doctor and the patient and the kind of delivery you're saying. You might assume that every patient from Apollo is coming to Apollo Home Care, and I might say that Apollo Home Care might not get patients from a Fortis or a Max or a Medanta for the fear of a doctor saying that this patient will go to Apollo. So there are I would say gray shades both sides, but definitely I think brand itself, when you get a brand like Apollo, that helps you, and that has again its advantages and disadvantages. But I feel that when you are doing a job different of a hospital, your focus is completely that only, and hence when you have that focus, things happen a bit differently, and the evolution happens a bit differently. So that's my take on that, sir.
Very good. And then perhaps your focus and search of excellence might be able to distinguish you as a partner for other hospitals who might want to compete with Apollo and who find you the best in that space and they come to you at favorable terms.
Absolutely.
So
that's what has happened. That's what has happened. Absolutely.
Oh, that's already happened. Okay, great. So coming with the last question to Mahesh, and that is regarding this has come from Anand Sheth, Director Titan International, as well as founder Curiosity, Harsh Gudru. Vis-a-vis institutional care, home care requires significantly higher skilled manpower because he has to do the work alone without the backup of many experts. How can this be solved, or will we keep using lack of manpower as reason for lack of scalability despite nearly a decade after home healthcare services companies have come in? So this skill gap in the home healthcare worker, how it can be comprehensively tackled so that he becomes autonomous, almost autonomous, or has very strong physician oversight so that he does not commit iatrogenic errors. Mahesh.
So I think first myth has to be busted is that you really require most of the time the high skilled worker in home health care. That's not correct.
Okay.
It's like even in the hospital, the number of critical care nurses are far lesser than the nurses that are serving the general ward or the special ward, etc. Right? There are specific skill sets that they need to be trained, not clinical skill sets. There are skill sets like empathy, compassion, communication, reliability, trust. These are the skill sets that people have to be trained into more than the clinical. And the success of home healthcare actually is how you can get a low skilled guy to, on a regular basis, upskill and add skill sets to them so that one, they can do better, they can earn better, they can care better, and then create effective monitoring system. I think this is where the organized players will be different than unorganized. Just sourcing a customer and deploying a nurse is just the beginning of the journey, because in the first 48 hours there will be at least 10 calls back and forth that happen between any client, educated or uneducated. But beyond that, how do you monitor this? One, physically; second, digitally; third is remotely. In these three ways how you create effective monitoring mechanism, and the more technology you use into this, your bandwidth will increase, your cost of care will come down, and your chances of things going wrong will come down. So I think one is on the clinical side, second is on the process side. I think the safety aspect of people is another important area to focus upon, and not just look at people from the point of view of clinical skill sets. I think the entire organization has to focus on the soft skills that I mentioned, because that is what people perceive at home, and that is what is the need most of the times for majority of the patients.
Excellent. So you have said skill sets are technical skill sets and soft skills sets also, and these latter should not be underestimated. They are very, very important in overall experience of the patient. Second thing you said is bring a tool set. Tool set like remote monitoring, digital monitoring, and other tools to make sure that quality service is given. Thirdly, you are saying bring an upskilling set. Often the attendant, after an hour of bathing, taking care, etc., of the patient is free, and he should not spend all that time watching the TV serial which the patient watches, or when the patient is sleeping. His routine should be so handled that he can upskill himself digitally. Great points. Super. So that was it. Fantastic discussion. Thank you very much, everybody. And thank you, the audience, for such fine questions and staying back in large numbers. Really, it keeps us encouraged. I pass the mic back to Siddharth.
No, thank you very much, sirs. It is truly a privilege and an honor. Our leaders and I have taken on so many nuggets from the conversation, and very well moderated, Mr. Choudary. Thank you for that. I'm still receiving positive messages from our leaders over email and LinkedIn. And thank you to our attendees and members in the audience for staying till the end and for sharing excellent questions. We will be taking these discussions on the digital exclusive platform, which is curated for leaders. And I started sending out invitations to over 2,000 leaders across our 4 sectors, starting with healthcare, energy, e-mobility, and real estate. So whether you would like to engage with us on our expert panel or as learners on the platform, we invite you to connect with us for membership and join the healthcare circle. All the details for the CXO platform are also available on the bluecircle.co. So thank you once again, our distinguished panelists and our leaders in the audience.